Today we will be talking about Chapter 17 in your Townsend textbook. This is bipolar and related disorders. We will be looking at the definition of bipolar, the nursing process as it relates to the bipolar disorder, and how it affects the patient and the family. We will also review some of the medications and the different types of bipolar disease. The objectives for Chapter 17 include review historical perspectives of bipolar disorder. So we're going to go back and we're going to look at the earlier writings related to bipolar disease and how it was looked at in earlier times. Discuss the epidemiological statistics related to bipolar disorders. Describe various types of bipolar behavior. We will identify the predisposing factors in the development of the bipolar disorders. Also discuss implications of bipolar disorders related to developmental age. We will identify symptoms associated with bipolar disorders, and we will be able to use this information in the client assessment. Utilize the nursing process to develop care, because the care for the bipolar patient needs to be specifically individualized to their needs and according to their symptoms. And the most important piece with bipolar is to keep the patient safe and from doing obscure and pieces and measures that will possibly lead to harm. Discuss treatment for bipolar disorder, such as therapy and medications. In the bipolar phases, you have manic, hypomanic, and depressive, and we're going to talk about these in depth. In the manic, you are very happy and elated, you're very hyper, and you do promiscuous activities such as spending large amounts of money with no thought of what it will do to you financially, sexual activities with multiple partners with no thought of contracting disease or illness. In the hypomanic phase and the depressive phases, this is where the patient goes from levels of high hyperactivity to very low. They're sleeping a lot, they stay in, they don't socialize, they don't eat, they don't bathe, they don't take care of themselves. They are almost in a catatonic state when they become in a very hypomanic and depressive, and we will discuss this later on. Susie is a 28-year-old with a diagnosis of bipolar. She has been extremely hyperactive. She has increased agitation and lack of control over her injurious movements. She displays some delusional thinking, hallucinations, and she's very impulsive with her activity. She's losing weight because she can't sit still long enough to eat a proper diet. She is experiencing delusions of grandeur. She is experiencing auditory and visual hallucinations and is somewhat disoriented to her surroundings. So 3 questions. You as the nurse, you have to make a diagnosis on this client. What would be your priority diagnoses? And I'm not going to give you the answer. I want you to critically think about this. And there are multiple, but think about what is the highest priority at this particular time. Look at the key words in the case study to direct you what is your number 1 priority for this patient. What nursing interventions are needed? How do you need to address all of these symptoms she is having? And what's the first thing you should do to help get her under control? Which type of medication would be effective? Look up the medications that go with bipolar and that treat the manic side of bipolar. Use your pharmacology book and use your resources. Bipolar disorders. So you have cycles of manic behavior with cycles of severe depression. Mania is an alteration in mood. It's expressed by feelings of being elated. You're so happy and hyper and everything in life is just wonderful and you're so social and cordial and you're doing very rapid movements and doing things that is out of touch with reality. your self-esteem is inflated, and you have a mindset of being grandiose, like you are a movie star or somebody of great importance. You're very hyper. You may be spending lots of money cleaning out your bank accounts and not even realizing what you're doing. But along with this, the patient is agitated because their thoughts are coming so fast, it agitates them that they can't do everything that these racing thoughts are having. So their speech is accelerated. They have what we call pressure speech because their thoughts are firing so fast in their mind, they can't get it out fast enough. Back in the historical perspectives of bipolar, in the earlier writings, bipolar was categorized as severe madness. In 1025, the Persian Empire, they wrote that mania was like madness of a beast, and you had rapid onset with remissions. They were agitated and very irritable. They even consider rabies as a type of mania because the patient acted so beastly and wild and would attack. Contemporary thinking has shaped the idea that manic depressive is widely accepted, back in the 1930s. Bipolar was categorized as manic depressive later on. So it used to be termed manic depressive, but now it is termed bipolar. So this is something you need to know. You need to be able to recognize the symptoms of bipolar and determine what is the priority for this patient. And the scenario in the slide before, I didn't give you the answer to that, but safety is one of the number one priorities. We've got to get the patient calmed down. We have got to get them back to hopefully a normal state of reality before they hurt themselves or somewhere else. So remember safety. That is a high priority with these patients. Also, we have to look at other things. Nutrition. They're not eating. They're not sleeping when they're manic. So they tend to lose weight, and this can go on for months. I'm not just talking days. This can go on for 4 to 6 months, and then they can have 4 to 6 months of depression, and then their appetite and nutritional value and all that's affected during that time as well. So what is the epidemiology or the cause of bipolar? About 5.7 million American adults are affected with bipolar disorder, and actually this number has increased from the time that this book was printed. It is more than that now. It usually occurs around age 18 or older. It can occur at younger ages, especially when a person is going through puberty and they experience these hormonal changes. Also, you may see some early onset. Average onset's around 25 years old. It's the 6th leading cause of disability in the middle-aged population. It is treatable with lithium, and lithium can control these episodes, but now lithium has some side effects, so you have to be monitored while you're on this drug. You don't just take it and never go back to the doctor. Plus, these patients need therapy too. It's not just with medication. They need to be in a routine therapy where they can be taught how to recognize their symptoms, keep their doctor's appointments, the importance of taking their medications, and staying on a regimen that will help control their symptoms. Bipolar can be hereditary. It can be caused from a genetic disorder. It can be caused from a chemical imbalance, or it can be caused from just learned behavior, like from a child that grew up in an abusive home. There's no specific identifiable factor. There are multiple factors that lead to this disease. So what are the types of bipolar disorders? So with bipolar, it is characterized by mood swings, and you have profound depression along with these mood swings. Sometimes you are manic, which is that euphoric state. You know, you're hyper vigilant, you just feel grandiose, you feel invincible, you just feel like you could take on the world and nothing's going to happen to you. But during this time, there are periods that the patient can feel normal, especially if they are on a treatment regimen. They're getting therapy and they're taking their medications like they're supposed to. Delusions and hallucinations may or may not be present. All people who have bipolar do not experience this. Some people just experience the irritability, like being in a large crowd. They can't tolerate a lot of socialization because the noise and all the movement of being confined irritates them. The manic episode, you are in an elevated mood state. It is very expansive. It can last for months, but you're very irritable. Like I said before, you just can't get things done fast enough because your thoughts are racing so fast. You have impaired functioning related to the ability to hold a job. Because of the irritability, things in a stressful work environment irritates you even more. You're trying to get your thoughts out, but nobody really wants to listen to your rapid speech, so that irritates the person. The bipolar patient has difficulty with social relationships, especially in the manic state. They're so hyper vigilant, they can't stay within a relationship long enough. They have to be moving, they have to be doing things. But then when they're in the depressive state, they're sleeping all the time. They're not getting out. You can't reason with them. Motor activity is excessive. They're very frenzied. Their movement has no purpose. They're from here to there, and they're just constantly moving, and they can't be still. They're very fidgety. They're always in motion. On page 420, you have box 17-1, and this is your diagnostic criteria for manic episodes. Make sure that you read this on your own. It is a lot of material to just really go over in this lecture, but you can read this on your own. But look at number B. It says, during the period of mood disturbance and increased energy or activity, 3 or more of the following symptoms, 4 if the mood is only irritable, should be present. Inflated self-esteem or grandiosity, decreased need for sleep. They don't sleep when they're manic. They can stay up for days, 3 or 4 days at the time, because they are so hyper vigilant. Their body just is in that rapid mind state, and they can't shut down. They can't sleep. They're talkative, pressured speech. They can't get those thoughts out fast enough. They have flight of ideas and so forth, and you can see these in the box here. Their ideas don't make any sense. They want to get into adventures that in reality is going to cause them more harm than good, like spending money in a financial deal when they haven't even had time to investigate or assess the situation to see if it's even valid. So they're very loose. That's how we would describe them. Their behavior is loose. They have loose associations. Their connections don't make any sense. They are truly not thinking with common sense when they're in the manic state. Now on the other side, we have the manic, now we have the hypomania. This is a milder version of the manic episode, so they're not quite as manic, but they're on the verge. It's not severe enough for hospitalization. It does not include any of these psychotic features, but they may be irritable. You can tell it's coming. That's why it's so important to educate these patients on their symptoms, so they know when they're getting ready to experience an episode, so they can seek out help. On page 421, you have diagnostic criteria for the hypomanic episode. Make sure that you review that and know some of the information. Look on 421, it says, note, a full hypomanic episode that emerges during antidepressive treatment or electroconvulsive therapy, but persists at a fully syndromal level beyond the physiological effect of that treatment, is sufficient evidence for a manic episode diagnosis. Caution is indicated so that one or two symptoms, which is usually increased irritability or agitation, are not taken as sufficient for diagnosis of a hypomanic episode, nor necessarily indicative of a bipolar situation, because we all have times where we're irritable. But if you are truly diagnosed with bipolar, before you're getting ready to go in that true manic episode, one of the first symptoms you may see is this irritability state. So the patient needs to know, I'm starting to get a little irritable here. I just feel like I'm getting on the edge. They need to seek out, treatment, or they need to make sure that they're taking their medications. They need to go in and see their physician before they harm themselves and get into a full-blown manic episode. Now, we have different levels of bipolar. So bipolar 1, this is where you have the diagnosis and you are experiencing a manic episode, or you have had a history of one or more manic episodes, and it's during a specific time frame also. And in order to be truly diagnosed, it has to be within the time frame. And your book really doesn't specify the time frame, but the diagnostic criteria book will give the time frames for these different levels. They may experience episodes of depression during this time, and they may be psychotic, or they may have those canatotic features where they, are in a catatonic state where they don't want to respond, they don't want to talk to you, they don't want to move, they may be balled up in a ball in an odd shape, their body looks disfigured during this time. So now we have bipolar 2, and this is characterized by these recurrent bouts of major depression with episodic occurrences of hypomania. So you have the depression going on, and then you're on the edge of that manic state. You can go from depressed to this irritability, a little anxious. You're just on the edge of having a full-blown manic episode. The client has never experienced a full manic episode in bipolar 2. The symptoms are not severe enough that causes impairment in socialization or their ability to maintain their occupation, keep their job. They do not need hospitalization in this state, but they do need to go see their doctor. They need to make sure they're taking their medications. Maybe their medication needs to be adjusted. Maybe there's something going on in their life that's causing them to experience these episodes. Maybe they're having issues at work or financial problems or relationship issues, but this does need to be assessed, and physician needs to look at this patient so they can make the necessary adjustments. Now we have the cyclothymic disorder, and this is chronic mood disturbance of at least 2 years duration. So this bipolar, once it's full blown, there's no cure for it. It's treatable, but you can't make it go away. And so now when you are in the cyclothymic state, you have had a long duration of the mood disturbances. You have numerous episodes of elevated mood that do not meet criteria for a hypomanic episode, numerous periods of depressed mood or insufficient severity or duration to meet the criteria for major depressive disorder. The individual is never without symptoms more than 2 months. So they experience these symptoms on an ongoing basis, and your diagnostic criteria for cyclothymic is on page 422, box 17-3. And for testing purposes, I don't expect you to know everything in these boxes. It's too much to learn. But just make sure you read over these so you have an understanding that there are time frames and that they're experiencing different symptoms in the different levels of the bipolar. Now, there are other types of bipolar categories. You have substance and medication induced. So if this is the case, then this patient definitely needs to be assessed. Their symptoms need to be ruled out. Is it related to intoxication, such as alcohol or amphetamines, cocaine, hallucinogens, inhalants, opioids, sedatives, hypnotics, anxiolytics? Symptoms can also occur during withdrawal from substances such as these two. So we need to rule out, is this patient truly bipolar? Are they experiencing these symptoms, or are they experiencing withdrawal symptoms from medications? That's why it's so important to tell the patient that they need to go see their physician. They need to get assessed by the proper medical personnel. Also, another type is bipolar due to another medical condition, and in this, it's characterized by abnormalities and persistently elevated, expansive, or irritable mood and excessive activity or energy that is judged to be the result of direct physiological consequence of another medical condition. So it could be anything. Here it talks about distress or impairment in social, occupational, or other important areas of functioning. When it's due to a medical, say it could be a stroke patient. Stroke patients have personality changes, and so they may experience episodes of depression or mood changes when experiencing a stroke. An Alzheimer's patient, so that has to be ruled out also. So what are our predisposing factors? And I've kind of already mentioned this, and the book did a good job giving you a list. Genetics, that's one reason there's no cure for it, because if it's genetic based, we can't fix our genes. Certain chemical imbalances such as norepinephrine, dopamine, serotonin, and acetylcholine. So a lot of the medications that are used to treat bipolar are used to correct these imbalances with these certain chemicals that are within our brain. Physiological influences such as decreased brain functioning. You may have a stroke, like I said, or Alzheimer's that causes you to have bipolar type symptoms. Medication side effects from steroids, amphetamines, antidepressants, high doses of anticonvulsant medications, and narcotics, because we know all of these types of medications can alter our mental status. And then psychosocial theories such as schizophrenia. Some people have other mental health diseases together. Sometimes you just don't have just one. Sometimes when you're bipolar, you can also be schizophrenic, or you can have schizophrenia that causes you to be depressed a lot, or have these manic episodes, because you hear in schizophrenia, you hear these voices in your head telling you to do things. So it could be related to any of these factors, and these need to be addressed so the proper treatment and medications can be prescribed. Maybe the person doesn't need something for serotonin imbalance. Maybe their serotonin levels are fine. We need to treat exactly what the particular cause is. Now, you can treat bipolar with certain medications. So your mood stabilizers are lithium, divalproex, and carbamazepine. Divalproex is also Depakote. That's another term for it. And carbamazepine is an anticonvulsant medication. You also have certain atypical antipsychotics such as lazepine, quetiapine, risperidone, and riprazole. And so, and you guys, this book is a couple years old, so there's even more drugs out there. So if you decide to go into mental health, as a nurse, you want to look up these new medications because they all have side effects, such as lithium. You have to have blood levels drawn. You can get toxic from lithium very quickly. Carbamazepine is an anticonvulsant medication. You need to have blood drawn done with that to make sure that you're in a therapeutic range. Depakote's the same way. If you your Depakote levels are too high, you can't give this medication because it will cause adverse reaction and actually make the condition worse. So, these are just a few listed for testing purposes. Just know, the names of these that I have listed here. But there are many out there. There are many drugs for bipolar. Some of the side effects of bipolar is dizziness, lightheadedness, so the patient's at risk for falls. A lot of these drugs require them to go in and get routine labs done once a month, once every 3 months. Sometimes these medications have adverse reaction and cause them to have even worse symptoms. So if you see a change in the person's mental status that's not back to normal, but it's worse, the patient needs to be taken off that medication and definitely assessed by the physician. We definitely need to call the healthcare provider. And the patient needs to be educated about that. They need to be taught about the signs and symptoms of their medication, and you should have had that in your pharmacology class. I also wanted to mention as another treatment is family intervention, because patients and their families, they need counseling. They need to know how to handle these disruptions. They need to know how to recognize a relapse of symptoms. They need to know preventive measures, and they need to know the importance of adhering to the treatment regimen, staying on the medication, going to the doctor, recognizing the symptoms, getting the person help when the condition gets worse. Because a lot of times these patients are not able to hold a job, so they depend on family members to take care of them. And so the family or whoever the caregiver is or significant other definitely needs to know when the patient is actually in a manic or depressive state, and get them to the doctor. Even if it's not time for their checkup, they need to take them back and have someone assess them and assess their medications and adjust their medications and their therapy to help relinquish these symptoms. Family members need to be educated. They need to know what to look for, because sometimes when these patients are in the manic mode, they may try to hurt whoever's taking care of them, and they may try to hurt them themselves, especially if they have other disorders like Alzheimer's and dementia and schizophrenia, because with those disorders, sometimes they have voices in their head telling them to harm themselves. So the family needs to be very aware of that. They need education. So with the nursing process, we want to look at background assessment. So in stage 1, hypomania, they're cheerful, expansive. They have underlying irritability. You can tell it's there, but it's still controllable. It surfaces rapidly when their desires are not fulfilled. So, like I said, it's there, and you can see it, and it will come out if they don't feel like their needs are being met according to the ideas in their head. Their cognition and perception of their self, they're very exalted about themselves. They think they are a great worth of somebody that's really important, that they have ability like superpower heroes. So we have to be very careful with these people to make sure that they're not thinking they're Superman and they can jump off the house and fly. They need to be safe. Their thinking is rapid. They have a flow of ideas. They have these rapid thoughts coming into their head. And they have what we call flight of ideas, just multiple ideas that don't make no sense. They're very dangerous sometimes. They have heightened awareness, and they're easily distracted because they can't focus. They're so hyped up they can't focus. Their behavior, again, they are very agitated. They have motor agitation. They can't be still. They're extroverted. They just, grandiose with their behavior. And they dress promiscuously, lots of makeup, flashy jewelry, flashy clothes. They're very sociable. They lack depth of personality. They're very flat with their affect. Their personality seems happy, but they may laugh inappropriately when something's said that you shouldn't be laughing at. Increased libido, so they're very sexually oriented, and they will often have sex with multiple partners. Even if they're obliged to someone, they may cheat on them. Again, weight loss inappropriate behavior such as excessive buying or spending. They have no idea of realistic thinking and what this is going to do to them financially when they're spending all of this money. So as we continue with the assessment, we're in stage 2, and this is acute mania. They're very euphoric. The elation is unbelievable. You just have to be around someone like this. They are elated for a long period of time, days, without sleeping. It's almost like they are on a continuous high. They say things that don't make any sense, and it's almost like you would say, oh man, their head's in the clouds. Their mood has frequent variations because it changes easily. Sad, irritable, crying, laughing inappropriate, ha ha ha, you know, happy and sociable, and then they're just like down. Flight of ideas, there's that accelerated thinking again. And again, this is the acute manic stage. Pressure speech, they're incoherent. What they're saying doesn't make any sense. They are not coherent. They're incoherent. They often are saying things that don't mesh in a realistic state. The activity is excessive. Sexual interest is increased. Again, they spend a lot of money with no thought that it's going to break the bank. They don't sleep for days. They don't eat. They don't bathe. They don't change clothes. So they often may put on layers of clothing and jewelry, and they haven't even taken a bath. So they may have some body odor. So they think they look grandiose, but in reality, they actually look disheveled. And so as a nurse, you need to be assessing this type of dress and attire and assess their hygiene as well. So in stage 3, they are delirious mania. So this is pretty bad. It's severe clouding of consciousness. Antipsychotic medication may help in this stage, but they're going to need a constant regimen. They may even need an IM injection or an IV medication to get it in their system and help calm them down. They're very labile. Their affect is flat, and you can't reason with them. You just can't reason with them. They have feelings of despair. I'm going to die. This is the end of me. And like I said, they're very grandiose with that. This is the end of me. I'm going to die a vicarious death. Quickly converting to unrestrained merriment and ecstasy or becoming irritable. And they're totally indifferent to the environment. If they had a family member that was in a car wreck, like I said, they may laugh inappropriately. It makes no never mind to them because they're not in reality, don't understand that this person's been injured and they're hurt. And they don't realize that they're hurting their family. They have panic anxiety. Their anxiety is so elevated that they may be in panic mode. Oh my God, what am I going to do? Oh, I don't know what to do. I've got to buy this, I've got to buy that, and oh, I need to go out with you, and I need to do this, and oh, just go, go, go. And they really act like that. Clouding of consciousness, they're disoriented, and they can often be stupor. Like they're so elated and high, it's almost like they've been smoking marijuana or something, you know. It's like just, oh, the world is spinning around and it's spinning around me, and just, oh, you know, I can see the heavens. They're exhausted. They have injury to self and others, and eventually death could occur because they are not taking care of themselves, and they could harm themselves in this state. So now our nursing priority changes. Well, not really. It's still a safety issue, but now we may need to look at risk for suicide, and risk for suicide is a high priority. Even though it's not an actual diagnosis, risk for, when it comes to suicide, is one of the main priorities. The diagnoses and outcomes criteria, this is on page 426, and it is 17-1, and this is your table, excuse me. And also it is listed on page 427, your outcome criteria. And the biggest thing that you want to see is the patient is now not exhibiting any evidence of physical injury. They have not harmed self or others. They're calmed down, they're eating, they're willing to take a bath, they've slowed down, no hallucinations, no hyper activity. Please review table 17-1. 17-2 is the care plan. Make sure you read through the care plan. It goes all the way from 427 to 430. And you have different interventions for, like, diagnosis number 1, risk for injury. What would be your nursing interventions? You want to keep the patient safe. Please read all of these interventions. You will see some of these on the test. On page 428, risk for violence, you have like 7 interventions there. You want to make sure the environment is low stimuli, and you want to have a calm attitude. And when the patient is in the manic state, you want to do what's called talking down, or you have to calm them down by using medication. But you want to try talking down first. Calm, keep your distance because you don't want them to hit you. They may see you as a threat. Call them by name, calm voice, calm tones. And here's what you do. You don't say calm down. You say, tell me what's wrong. What can I do for you? What do you need? Make sure you read these interventions, okay? There are several. And then on page 429, you have imbalanced nutrition. So we want to give high protein foods. We want to make sure that we're weighing them appropriately on a daily basis. Give them supplements that have nutritional calories in it. We've got to get some intake in them. And then on page 430, it talks about impaired social interaction. How do we get them back to socializing again, interacting with other people? But you can't do that until you get them calmed down first. So the priority is to get them calmed down first. Please make sure you review the care plan on page 427 through 430. There will be test questions from the care plan. So some of the treatment modalities include psychotherapy, group therapy, family therapy, and cognitive therapy. In psychotherapy, this is where the clients are assisted to regulate their social rhythms, their daily routines, such as sleep, bathing, eating, dressing, going to work, getting back to their normal life, helping with their interpersonal problems. So the psychotherapy is going to deal with the psyche, their mind, and help them basically rethink how they're doing things. We're going to give them a new way to look at things, but they do have to be open and accept this too. They've got to be willing to do it. Group therapy. So once the acute phase is over, remember during the acute phase, the priority is to get them out of the acute phase, keep them safe, reverse the manic episode. So in group therapy, you want to discuss, are there any issues in your life causing you to be depressed or manic? Peer support. Who's here to help you? Who do you trust? Gain a sense of perspective of the condition. They need to understand that they didn't do anything wrong. A lot of people feel like they did something wrong, that's why they're sick. They need to understand that it is an illness and it is a disease and it can be controlled. And we need to give them or help them understand to have hope because it is treatable, but we don't want to give them false hope. So you give them hope by helping build their self-esteem, saying stuff like, oh, I'm proud of you. You got yourself a bath today and got yourself dressed. That is a milestone for them, and we need to give them positive reinforcement to address that. And of course, family therapy, and I've already discussed that. And then cognitive therapy, here is where they're trying to help you develop a way to control the distorted thoughts that you have, a different way of thinking and how you perceive yourself. Now you also have a topic called automatic thoughts, and this is where the patient has 4 different areas that they may experience. So under these automatic thoughts, and let me get to that page in your book, personalizing. So they may be, I'm the only reason my husband is a successful businessman. And the book does give you different examples, so make sure that you read through these examples. The all or nothing, everything I do is great. And so they think because of themselves that, what's going on around them was done specifically because of them. And so they just think they're great. Okay. Mind reading. She thinks I'm wonderful. So they have a distorted thinking that when they're in this manic state, that somebody may think, not somebody but themselves, they think that the person thinks they're just this most fabulous, very important person. And discounting negatives. None of those mistakes are really important. Like I said, they don't deal in reality, so they don't really understand that, this is important and this could cause harm to you or to someone else. So these are those automatic thoughts. The drug of choice for bipolar is lithium. But again, like I said, this book is a little dated and there may be some other medications out there, but lithium is still very widely used. And for testing purposes, you will need to know about lithium. They've also had success with using certain anticonvulsants such as the carbamazepine, and you can be symptom free. You can live with bipolar and live a normal life. It works really well, and it's an old drug. It's been around for years. On page 435, table 17-3 lists some medications. Definitely look at lithium, carbamazepine, which is Tegretol, Depakote, which is your valproic acid. I do want you to know at least those three, okay? Please make sure that you look at that. You should be familiar with all of these from your pharmacology class. Lithium levels should be 0.6 to 1.2. When you exceed this level, this range, you can have very fatal toxic side effects. And so the patient needs to make sure that they're going in to have their lab work done, and it's usually every 1 to 3 months. Some doctors will do 1 month, some will do 3. So they need to have their labs done. And they need to know that if they're exhibiting vomiting or diarrhea, these can result in sodium loss and increased risk of lithium toxicity because of that sodium loss. And the last slide is about lithium education, and it covers page 434 through 440. And I do want you to read through these. And yes, you need to read those pages because there's lots of information here about lithium, and it is all important. Starting on page 434, take the medication on a regular basis. Do not drive because dizziness can occur. Don't skimp on dietary sodium. You should eat a variety of healthy foods and avoid junk foods. Drink 6 to 8 large glasses of water each day and avoid excessive use of beverages that have caffeine, such as coffee, teas, and colas, because this promotes increased urine output, which causes you to lose sodium. And lithium does affect your sodium levels, so you need to make sure that you're not doing anything to lose sodium. Again, diarrhea or vomiting, and that needs to be reported. Carry a card to identify that you are taking lithium. Be aware of appropriate diet should weight gain become a problem. Be aware of risk becoming pregnant. Be aware of side effects and symptoms. Notify the physician if you have persistent nausea, vomiting, diarrhea, ataxia, blurred vision. Follow these rules. Also on page 439, you do not want to discontinue the drug abruptly. You want to report the following symptoms, and this is for anticonvulsants, on page 439. I got ahead of myself, and I do apologize. On page 439, it goes from lithium to anticonvulsants to calcium channel blockers to antipsychotics. Just make sure that you know that taking these medications can be dangerous and that there are side effects. So please read through these pages because you will see some of this information on the test. The end of my PowerPoint includes some practice questions for you. Please review these and let me know if you have any questions. I'll be glad to answer your questions. Just email me and we can set up a time to meet. Thank you, and I hope that you enjoyed my PowerPoint on bipolar. I know we went through it kind of rapidly. Please go back and read the content that was covered on this PowerPoint, because that will direct you to the core pieces that you need to study for. Thank you, and please let me know if you have any questions.